First, I'm going to ask a little bit of an audience participation question about hormone replacement therapy. How many women out there are taking hormone replacement? Press 1 on your keypad if it is yes, and press 2 if it's no.
And only the women, okay, men?
Oh.
And you can't answer for your wives.
Okay, we have a resounding 92% no and 8% yes. And this is very similar to what I see in private practice. About anywhere from 5 to 10% of my patient population is taking hormones at any time. So moving on to hormones in women.
So is that a good or a bad thing, Wendy?
Hormones in women?
Yeah.
We definitely need them, and we're going to talk a little bit about the way that they work. So menarche is when women first start getting periods, and we get pretty cyclic periods through the childbearing age, and then perimenopause hits. And everybody knows about perimenopause and menopause. Perimenopause is the time where women's periods start to skip, symptoms can start to happen, and then menopause comes. And menopause is a clinical definition. People always say, should we draw some hormone levels? Well, it's really a clinical diagnosis, and menopause is defined as a full year with no menstrual period. So in terms of hormone replacement, what is it that we're replacing? Is it estrogen? Is it progesterone? Is it testosterone? First of all, we're going to talk a little bit about what the benefits are of replacing hormones. Some women need to have hormone replacement and some don't. Mainly, women who need hormone replacement therapy are the ones that get severe vasomotor symptoms, hot flashes, night sweats. These can be completely debilitating. Some women get mood changes and insomnia. Some women start to develop cholesterol problems, that when they had no cholesterol problems before their menopause, all of a sudden their good cholesterol, the HDL, starts to go down, their bad cholesterol starts to go up, so hormones can definitely help that. There are issues with osteoporosis once people go through menopause, and certainly sexual issues. Decrease in estrogen leads to decrease in libido, and decrease in testosterone as well leads to decrease in libido, and certainly vaginal dryness and painful intercourse. So as another question, women who have symptoms in the menopause always ask themselves, well, if I go and start taking hormone replacement therapy, am I going to get side effects from it? But the biggest question that people ask is it going to increase my risk for breast cancer? So on the keypad, I'd like you guys to give me a response. Does hormone replacement therapy greatly increase my risk for breast cancer? Press 1 if you think the answer is yes, and press 2 if you think the answer is no. And we have 65% saying yes and 35% saying no. Well, everybody's a little bit right in this situation, and I'll explain why. The Women's Health Initiative study that came out in July of 2002 looked at risk of hormone replacement therapy, and particularly with breast cancer, I want to tease that out a little bit. And there is an increased risk of breast cancer. And again, that was the turning point for hormones. Many women came off hormones very rapidly during this time. Everybody was afraid because of the increased risk of breast cancer. But there isn't a tremendous increased risk. It is significant, but it's an extra 7 to 8 cases of breast cancer per 10,000 women. So for the individual woman who's very symptomatic and miserable with hot flashes and night sweats, it may be worthwhile, and the risk-benefit ratio may lean in favor of taking those hormones if they're very, very symptomatic, as the risk is only 7 to 8 extra cases per 10,000 women.
Now, is that more, Wendy, if it's somebody, if you have a family history of breast cancer, is that factor into this?
That's a great point that you bring up, because remember, these decisions are made as a partnership, doctor and patient. We come together, we talk about your personal history, we talk about your family history. If somebody has a very significant family history for breast cancer, that may be somebody that we want to give an alternative therapy to, something that's not hormonal, which we're going to talk about afterwards. There are lifestyle changes, there are exercise modifications and dietary modifications, as well as non-hormonal medications that we can use.
Wendy, is there a way to detect or predict whether a person is going to have a risk of cancer using these medications? Is there a blood test or anything like that?
Oh, I wish there was a blood test. I wish there was some way that we could really predict and tell. All we can do is look at personal history, we can look at family history, and we also certainly can be very careful in our professional breast examinations, our use of imaging like mammogram, but right now there's no blood test in which way to predict.
So Wendy, going back to you said, so if somebody had a hysterectomy with their ovaries removed, there's no increased risk of the hormones, correct?
Exactly. And this is, on this slide we see that this small increased risk of breast cancer only occurred in the arm of the Women's Health Initiative study where women had a uterus and they needed to take estrogen plus progesterone. If you don't have a uterus and you've had a hysterectomy, and you're taking estrogen only, as you don't need progesterone, there was no increased risk of breast cancer at all.
So then shouldn't all women have hysterectomies after menopause and then be on hormonal replacement? What is it?
We try to stay away from that. We take a little bit of a more modest perspective. So once we decide together as a partnership that somebody needs hormone replacement therapy, what type of hormone do we use? Do we use bioidentical hormones or synthetic hormones? And there's been a lot out there these days about bioidenticals. And what that means is this is what your ovary used to produce before you went through menopause. Synthetic hormones are what was studied in the Women's Health Initiative study, Premarin and Prempro. And Premarin is actually generated from pregnant mare urine. It was actually created from horse urine, so it's kind of synthetic. But there are bioidentical regimens out there that are FDA approved that work wonderfully, and we do believe that these are better and safer. When we're talking about the types of hormones, we also have to decide how we're going to give it. Are we going to give it by mouth, orally? Are we going to place a skin patch? Or are we going to put it in a vaginal ring? There are a lot of great alternatives out there. And then we also have to decide how we're going to give it. Some women are given hormones in a sequential way, which means they get estrogen every day and progesterone for just part of the month, and they get an actual period. Other women are given continuous hormones where they're given it estrogen and progesterone in the same dose every day. And recent studies are coming out showing that it's better to give continuous therapy to women. There's less of a risk of endometrial or uterine cancer in this way.
Wendy, can I ask a question? So if you're giving it, let's say, we give as urologists sometimes for recurrent infections, give hormonal therapy topically, vaginally. Does the risk of breast cancer increase with the topical local therapy also, or is it just with oral or systemic administration?
Yeah, there haven't been any wonderful studies looking at the differential risk of breast cancer in terms of whether you give it orally or whether you give it by patch. There are some benefits to giving hormones in patch form, and there are some benefits in giving it orally, but in terms of the risk of breast cancer, the only really big studies have really been done on oral therapy.
You have a question over there.
Is there a question? Yes.
Can you get a microphone there? Is there a microphone nearby? Thank you so much.
What if you don't have any major symptoms? Would, in fact, being on hormones keep you young?
Oh, that's a great question. And again, people come in all the time and they say, I don't have hot flashes, I don't have night sweats, but I really want my skin to stay good, and I want to be lively and have good mental acuity. And again, right now, because of the risk-benefit ratio, we sit down and talk about this on an individual basis. If you're not having any symptoms, we tend not to recommend hormone replacement therapy. Again, it's a very personal situation. Some women have other symptoms aside from hot flashes and night sweats, and they may really need to be treated. But without any symptoms, we usually, because the risk-benefit ratio leans in favor of not doing it, we tend not to.
Wendy, just a corollary to that question. Some of the items you have up here, particularly the vaginal ring, Now that's a low dose, often used, as I understand it, unless you're using it for systemic therapy, is used for vaginal dryness, lubrication, sexual issues in particular. Would that be similar to what you were talking about? Would you be contraindicated in women with a history of breast cancer?
This is a very interesting point, because what I have here on this slide in terms of talking about vaginal ring, I'm really talking here about systemic hormones in terms of the fem ring, where we're delivering the same dose that's going in your bloodstream as we would give it whether it's in patch form or oral form. This is to be differentiated from something else called the S-string, and the S-string is just the topical form of estrogen, and the S-string, as well as the tablets that we use vaginally, the Vagifem tablets, which we'll talk about a little bit later, are wonderful in ameliorating the symptoms of vaginal dryness and painful intercourse, but they're not absorbed systemically. And many of us use these preparations even in women who have breast cancer with the approval of their oncologist, because they don't raise your estrogen level, and they really are the savers of the sex life. Yes, question?
Get PET scans to make sure they have no tumors whatsoever in their bodies, but they're very expensive. And there's also the idea that perhaps if you have a tumor somewhere in your body that's gone undetected, and then you're taking hormones, you're going to increase the growth of any of those tumors if they exist.
Yeah, that is definitely correct. And believe me, as physicians, we're all looking for that blood test or that imaging study that's going to give us that thing that's going to be able to tell you, no, you're not going to be the one that's going to have that small indolent tumor become evident because of the hormones that we give you. But right now, none of that is available.
Wendy, may I answer that question? Because it's something we hear all the time in men, because with hormone replacement. But if you think about that logic, since everyone has hormones in their body, then everyone would have cancer. Hormones are natural. I mean, that's the reality of the situation. We are always making tumors, continuously. We're all making cancers in our bodies, and our own immune system is keeping it in check. And as Dr. Fried said, it is very nebulous, and there are certain tumors which are hormonally sensitive, but those are an extremely small percentage. And so to damn hormones in everybody because of the fear of tumor doesn't make sense. It really doesn't. And you have to individualize it with a family history, etc.
Right,
and there is no blood test. The ultimate is
isolated?
the blood test, which is, you're absolutely correct. It needs
Right.
to be a cheap, easy test for everyone to be tested for risk.
Have they isolated which tumors would be more sensitive to having hormone replacement? I know, of course, the breast cancer.
Yeah, there are, especially in female cancers, breast cancers are hormonally sensitive, uterine or endometrial cancers are hormonally sensitive, ovarian is not, and cervical is caused by a sexually transmitted virus, so that's certainly not hormonally sensitive
Okay,
either.
so, but they haven't really come out with thyroid, lung. Yeah.
No, melanoma is also, as an aside, it's estrogen receptive.
Thank you.
A question about the use of vaginal estrogen. What is the impact on your male partner?
Well, again, this is very interrelated, in terms of sexual activity. We see people who really have no sexual life because menopause has caused them to have a dry vagina. They're uncomfortable, they're miserable with intercourse, they start to decrease their frequency of sex until it becomes almost nothing. And then we give them these vaginal estrogen preparations, and they're really wonderful. They revolutionize the sex life in many cases. They don't have any impact on the male at all. The amount of estrogen in these vaginal preparations is minuscule. So men should not have any type of side effect from these preparations.
Thank you.
All right. And very importantly, the first place that we start with our patients, before we even jump to the hormone situation, in terms of people who are having significant vasomotor symptoms, hot flashes, and night sweats, are just basic things like dietary modifications. Sometimes just decreasing caffeinated beverages, decreasing hot beverages, red wine and peanuts, eliminating those from your diet sometimes helps tremendously on its own. lifestyle modifications like wearing layers of clothing, thin clothing, sleeping in a cool bedroom, getting excellent exercise can also help with these menopausal symptoms. And then moving to some over-the-counter medications if symptoms still persist, like a little black cohosh, evening primrose oil. Sometimes that works very nicely. And then if none of that works, before we jump to hormones, oftentimes we deal with non-hormonal prescription medications. We give you a clonidine patch. Clonidine is a blood pressure medication, which when used in patch form, we put it on either the upper arm, the belly, or the buttocks, on a weekly fashion, also significantly decreases hot flashes. Otherwise, we have serotonin reuptake inhibitors and Effexor, which are antidepressants. We use these medications in low doses to treat menopausal symptoms, and they're treated very, very effectively. Of course, there's no free lunch in life. There's always side effects with these medications, and particularly the antidepressants can also cause a little bit of a decrease in libido, and they can also cause weight gain, which nobody wants at any time, but especially not in the menopause. And question here, before we start talking about the risks of hormone replacement therapy, aside from breast cancer, just like Dr. Cavusi brought up before, it's very important to know whether a woman has a uterus or doesn't have a uterus in determining which type of hormone preparation we use. So press 1 if you have had a hysterectomy where they only removed your uterus. Press 2 if you've only had your ovaries removed but still have your uterus. Press 3 if you've had both your uterus and ovaries removed, and press 4 if you have had no surgery in terms of removing uterus or ovaries. And obviously, this is a female-only question. Okay. So we have a little bit of everything here, and now I'm just going to go over briefly some of the other risks of hormone replacement therapy. And again, that Women's Health Initiative study looked at those two arms, estrogen and progesterone in a woman who has a uterus, and estrogen only in a woman without a uterus. The risks are very, very different. There are an extra 7 to 8 cases of stroke, heart attack, and breast cancer per 10,000 women in women who use combined estrogen and progesterone with a uterus. And there are an extra 15 cases of blood clots per 10,000 women. When you look over at the estrogen-only arm in women who've had a hysterectomy, again, only 7 to 8 extra cases of stroke per 10,000 women, but no increased risk of breast cancer. So it's very important in terms of us deciding what we're going to do in terms of the hormone preparations that we're going to use based on whether or not a woman has or has not had a hysterectomy.